Think about the human heart for a second. It's this beautifully synchronized, high-performance engine, right? But what happens when a newborn enters the world and that vital engine is wired completely backward from day one? It's a terrifying reality, but the medical journey to understand and actually fix this defect is literally nothing short of extraordinary. In this explainer, we're diving into a congenital heart defect called total anomalous pulmonary venous connection, or TAPVC for short. We're going to break down the anatomy, the ticking clock these tiny patients face, and the life-saving surgeries that have completely revolutionized their outcomes. So let's imagine the human heart as a high-stakes plumbing system. Normally, oxygen-rich blood comes fresh from the lungs and flows straight into the left atrium of the heart, which then pumps it out to nourish the whole body. But with TAPVC, the pipes are, well, they're miswired. All of the pulmonary veins, the pipes that carry that fresh oxygen, completely fail to connect to the left atrium. Instead, they loop right back to the right side of the heart. You can see the crisis here, right? All that vital oxygenated blood has absolutely no direct path to get out to the rest of the body. At its core, the biological problem we're dealing with is a total lack of connection. In TPVC, there is absolutely no direct path between any of the pulmonary veins and the left atrium. Instead, all that returning blood just dumps into the right atrium, or one of the veins leading into it. Because of this massive detour, the left atrium is completely cut off from its normal supply of oxygen-rich blood. And since it wasn't forced to pump that blood and grow during embryonic development, it usually ends up being abnormally small. Now, you might be wondering, how on earth does a newborn survive even a single hour with this setup? Well, they survive because of a biological loophole. For there to be any chance of life after birth, there has to be some kind of communication between the systemic and pulmonary circulations. Basically, almost every single baby with TAP-heavy has what's called a patent foramina valley, or an atrial septal defect. It's essentially a hole in the wall separating the heart's upper chambers. And that hole is an absolute lifesaver. It allows the oxygen-rich blood that's trapped on the right side to spill over into the left, acting like a common mixing chamber, so at least some oxygenated blood makes it out to the baby's body. But here's where it gets even more complex. TAPVC isn't just one single monolithic defect. It actually shows up in 4 distinct anatomical variations, and it all depends on where those rogue veins end up going. The breakdown is pretty fascinating. Almost half the time, about 45%, we see the supracardiac type, where the connection happens above the heart. 25% are cardiac, connecting right to the heart itself. Another 25% are infracardiac, plunging below the diaphragm. And finally, about 5 to 10% are a mixed type, where the veins just split up and drain all over the place. Let's zoom in on that most common variation for a second, the supracardiac type. What happens here is the individual pulmonary veins actually come together into one common pulmonary vein, right behind the heart. But instead of going into the left atrium like they're supposed to, the blood travels up a left vertical vein and drains into the left brachiocephalic vein, or the superior vena cava. So all that vital oxygenated blood takes a massive detour above the heart before getting dumped right back where it started, in the right atrium. Then there's the cardiac type, which makes up about a quarter of cases. And honestly, it's incredibly ironic, because the veins get so close to their proper destination, but they still completely miss the mark. Here, the common pulmonary vein connects directly to the coronary sinus, which is the heart's own primary vein, or sometimes it dumps right into the right atrium itself. So the blood actually makes it back to the heart, but it ends up completely on the wrong side of the wall. Now, things get incredibly critical with the infracardiac type, which is also about 25% of cases. This is a particularly severe form of the defect. Instead of going up or straight in, the veins literally plunge downward, right through the diaphragm. They usually hook up to the portal vein in the liver or the ductus venosus. And as you can imagine, trying to push blood all the way down and force it through the liver's dense portal system creates massive resistance. That resistance frequently leads to really dangerous blockages in the venous pathway. Which brings us to the stark clinical reality of this defect. These newborns usually present as critically ill right out of the gate. The huge red flag is unexplained tachypnea. That's rapid, highly labored breathing. But the situation turns into a full-blown emergency if they develop pulmonary venous obstruction, or PVO. Remember how we just talked about those veins traveling long, weird routes? Well, those abnormal pathways can very easily get compressed or narrowed. When that happens, blood backs up into the lungs, causing severe pulmonary hypertension, fluid buildup, and it can rapidly lead to myocardial necrosis, literally tissue death in the heart muscle. It is profound distress. If we look back at the natural history of this disease before modern surgery, the data is just heartbreaking. 90%. That staggering number represents the percentage of infants with TAPVC who historically would not survive their first year of life without treatment. A tiny infant's heart and lungs simply cannot sustain that immense pressure and the chronic, exhausting lack of oxygenated blood being delivered to the body's organs. To really grasp the urgency here, we have to look at how an obstruction changes the timeline. If the abnormal veins are non-obstructed, the median survival for an untreated baby is about 2.5 months. Still incredibly short, right? But if those miswired veins become obstructed, which, by the way, happens in almost all infarccardiac cases, that median survival drops off a cliff to just 3 weeks. It is literally a ticking clock from the moment that child takes their first breath. They need immediate, highly precise intervention. Interestingly enough, doctors historically had a very unique visual clue for diagnosing this. Long before advanced 3D imaging, a doctor looking at a chest X-ray of an older infant with the supracardiac type might spot this iconic snowman or figure of 8 shape. The bottom round half of the snowman is the heart itself, and the head of the snowman, that's actually a massive shadow cast by the dilated left vertical vein and the superior vena cava, which are absolutely swollen with all that misrouted, backed up blood. Luckily, medical imaging has come a long, long way since then. Today, the absolute gold standard for diagnosing TAPVC is the two-dimensional echocardiogram. It's a non-invasive ultrasound, often paired with color flow Doppler, and it is remarkably accurate. It lets cardiologists clearly see that empty, echo-free space right behind the left atrium where the veins should be connecting but aren't. This tech is an absolute game changer because it gives surgeons the exact anatomical map they need without having to put critically ill newborns through the severe risks of invasive cardiac catheterization. The journey to getting these modern surgical solutions has been incredibly hard-fought. This anomaly was actually first described way back in 1798 by a physician named Wilson. But it took over 150 years until 1951 for Muller to achieve the first partial surgical repair using a closed technique. Then, in 1956, Lewis and Varco pulled off a successful open repair using surface cooling. From those early, incredibly risky pioneering days, surgical science just kept marching forward. Today, thanks to continuous cardiopulmonary bypass and hypothermic techniques, surgeons are routinely performing absolute miracles on hearts that are basically the size of a strawberry. So let's break down exactly how they do this life-saving open heart operation. It generally happens in 4 main steps. First, the infant is placed on cardiopulmonary bypass to keep their body oxygenated. Second, the baby's body is safely cooled, and the heart is temporarily stopped using a solution called cardioplegia. Step 3 is where the absolute magic happens. The surgeons find that rogue common pulmonary vein, open it up, and stitch it directly to the back of the left atrium. They are literally physically creating the vital connection that nature forgot. Finally, in step 4, they close up that atrial septal defect, the hole we talked about earlier, sealing off the old loophole now that the plumbing is finally routed the way it should be. Knowing the terrifying history of this disease, where 90% of untreated babies used to be lost, there's a quote from the medical literature that beautifully captures where we are today. It says, "Refinements in intraoperative techniques developed over the last 3 decades now allow excellent outcomes using continuous CPB." It's such a powerful testament to the relentless innovation of pediatric cardiothoracic surgeons. What used to be a near-certain tragedy has been transformed into a condition with a remarkably high rate of successful repair and long-term survival. But you know, the work isn't totally done yet. I want to leave you with this final thought. As of right now, prenatal detection of TPVC, finding it while the baby is still in the womb, is terribly low. We're talking under 2%. And because these babies can crash almost immediately after birth, knowing about the defect before they are born is absolutely crucial for planning the delivery and immediate care. As fetal 2D and 3D ultrasound technologies rapidly advance, early prenatal detection is going to be the next great frontier. Just imagine a future where every single miswired heart is mapped out completely before a baby even takes their first breath. How will that level of foresight completely reshape survival rates and ensure that every newborn's heart is wired for life? Thanks for joining me on this explainer, and remember to keep questioning the science that saves lives.